Welcome to the webinar, Innovations in Financing Environmental Asthma Home Visits within Medicaid. My name is Tracy Washington Inger, and I'm with the U.S. Environmental Protection Agency's Indoor Environments Division, and I will have the distinct pleasure of serving as your facilitator today. Here you see some of the issues that we'll be covering during the webinar. And next slide. So we are going to be talking a lot about community-based solutions today. So let's get started by taking a look at who comprises our webinar community today. So this map that you see here shows the states represented in our audience today, with the white states having no participants registered, and with the darker shading representing higher numbers of attendees. As you can see, we have a broad geographical representation, and California has really shown up to support our speakers and our great leaders from California. Next slide. And here we see a little bit about our organizational home bases as we come together for today's conversation. And it's really great to see this diversity of experience and perspectives for the topic that we're exploring today, because we need all of you to deliver comprehensive asthma care that brings asthma under control for all children. In the next slide here, we can learn a little bit more about what's bringing us together today. I'm pleased to say that we will be addressing all of the strategic priorities that you identified that connect your work to today's topic of financing environmental asthma home visits within Medicaid. Next slide. So as we begin, I want to ask everyone to please take a moment to participate in our Learning in Action poll. We want to have some idea of sort of how knowledgeable you feel right now as you come into this discussion about financing environmental asthma home visits within Medicaid. So heads up, we will repeat this poll at the end of today to compare before and after to see how well we've done in meeting our objectives, and we thank you for participating. So as you participate in the poll and identify where you feel like your level of knowledge is, you can begin now. But I also want to let you know that we will be using the chat function in the webinar interface to collect your questions throughout the presentations. And we will monitor that chat throughout the discussion to prepare a Q&A panel discussion at the end of the presentation. So please use that chat function throughout our discussion today to share your thoughts, your questions with our speakers, and so that we can discuss it at the end. And finally, we are recording today's session to make it available on AsthmaCommunityNetwork.org for all participants other than our speakers. So everyone will be muted throughout the session. Okay, so hopefully you've had a chance to engage in the poll, and let's see what it looks like here. All right, so we have a broad range of knowledge and experience here, but we can also see that, especially because many of you don't know some of the approaches that we're going to be taking, that there is a clear appetite and a strong appetite for deepening your knowledge on this topic. So I'm excited to welcome you to the first of a three-part webinar series here that the U.S. EPA Indoor Environments Division, or IED, will share, where we'll share solutions that any community or state can adapt and apply to address its indoor environmental determinants of health, or what we're calling IEDOH, to improve asthma outcomes. So U.S. EPA's Indoor Environments Division is your host today, and for the next few minutes, I just want to share a little bit about who we are and where we come from and what we know, so that you know what to expect in the webinar series that we're calling Solutions for Indoor Environmental Determinants of Health. And we hope to see you again in the next two sessions later on this fall. So I personally have had the privilege of working for many years in EPA's Indoor Environments Division's Center for Asthma in Schools, where we are fierce champions for children with asthma who need our help just to catch a breath. So because EPA is the federal lead for environmental risk reduction and standards of care, from 2006 to 2011, the Indoor Environments Division hosted annual national asthma forums to improve pediatric outcomes and to spread environmental and by spreading environmental asthma management. So core to our asthma mission in IED since the days of the National Forum has been the Asthma Health Outcomes Project, or as we call it, AHOP, which IED sponsored and which helped us identify, way back in 2007, the key drivers of high-performing asthma programs with environmental asthma management. And that's what you see here right now. So through AHOP, we learned from community-based asthma programs across the country, the system that you see here. And all of you taught us high-quality asthma care systems and how they emerge, and we translated that into this key drivers language that you see here of leaders and champions across sector commitment to delivering asthma care through collaborations and partnerships that integrate community and clinic with strong ties to the community most affected by asthma, and here is the golden ticket for us, and where tailored environmental interventions are available for the children who need them. So together, we have learned that these drivers make high-quality asthma care systems possible and make them run. And we have learned that whether they are payer, clinic, community-based, wherever they come from, asthma programs improve outcomes for environmental management when they break down silos. And that's what we see in this graphic. So at EPA, we know that overcoming silos, those silos is key for children who need environmental help to catch a breath. So since 2007, we have been studying how to build these systems, get results from them, and how communities can sustain them, including how to pay. So now at EPA, we and our partners and some of the leading asthma programs nationwide are sharing what we've learned in this webinar series because the time is ripe to solve for the indoor environmental determinants of health in asthma. And this is an all hands on deck kind of thing to put this system in place so that all children can catch a breath wherever they spend time. So we're really excited to have you learn with us. Okay? So next slide. At EPA, we've learned that high quality asthma systems exist. And then that, I'm sorry, if you can go back one slide for me, Pierce. We've learned that these high quality systems exist and that they look like this and that they break down silos to ensure indoor environments are addressed as a part of comprehensive asthma care. And IED is committed to helping all communities put their own version of this system in place because we know it works. So we've learned that these key drivers make systems possible and make them run and run successfully. So these drivers are the power source for community asthma care systems that reach children who need comprehensive care the most, including home environmental solutions. So what we have seen is as programs engage with these key drivers, those silo walls crumble, systems power up, and new models of care reach the children who need them the most. So as you look at our system and you hear me talking about these key drivers, this should all sound very familiar. The Indoor Environments Division and our partners, we had that same feeling. We're like, this feels familiar. And that was a reaction as the frameworks for social determinants of health have emerged and taken hold over the last 10 years. So it occurred to us that communities with the system for high quality asthma care in place have some of the social determinants of health solutions that healthcare is looking for, and in its search for partners who are ready to be accountable with healthcare for health outcomes. So what we saw when communities solve for indoor environmental determinants of health for asthma, they solve for problems at the intersection of housing, healthcare, and disparities. an intersection where also many of the social determinants of health overlap and pile up, especially for poor children and Black and Brown children. So our system for high quality asthma care is a social determinants of health solution. This is our learning as a community, and we are positioned to share it more widely. I'll take that slide. So what we have learned at EPA complements work by champions at all levels who have been committed to addressing the indoor environmental determinants of health and social determinants of health more broadly in asthma. So this has been, really great work with so many partners, for many years, because pediatric asthma disparities and the determinants of health in them are major national challenge. And so at the federal, state, local level, we have leaders who work together for years to find ways to reduce the disproportionate asthma burden for children. And the stories you'll hear from California today reflect progress nationwide, in part because of the longstanding federal effort to invest and partner to support new models of asthma care across states and communities. So EPA's Indoor Environments Division has been a leader with our Federal Family for Pediatric Asthma Disparities on the Federal Subcommittee on Asthma Disparities, which reports to the President. And just like we see in the System for High Quality Asthma Care, on the Federal Subcommittee, we're also breaking down those silos to drive better outcomes. So you see some of our collaborative cross-sector work here on this slide, and it describes how each agency leads in its own particular expertise, but also how we collaborate to help communities build and sustain asthma care systems that will impact asthma disparities. So the Asthma Subcommittee, is continuing its work today, and is particularly focused on three priority areas of expanding research coordination to leverage resources across agencies, to achieve equitable expectations for asthma outcomes for all children, and 3, broadening interagency and stakeholder collaboration for reimbursement of in-home asthma interventions. And that is the main thing that we're going to be talking about today and throughout this series. So for EPA, our distinct expertise has been building systems to address the indoor environmental determinants of health in asthma disparities, because this is the lens that brings into focus the critical role of in-home environmental interventions in comprehensive asthma care. So our story at EPA, our wheelhouse, right, our signature approach is to convene multi-sector stakeholders, has put us right in the middle with community-based partners, delivering in-home asthma visits at just the right time when home visiting, environmental services, and healthcare began really kind of turning to each other for new asthma solutions, new social determinants of health solutions. And we have been learning from and with the asthma programs addressing indoor environmental determinants of health and scaling and sustaining solutions for a long time. So now we're hosting as many stakeholders from across these sectors as we can reach to share what we have learned, because, well, first, we have technical solutions to share for the indoor environmental determinants of health in asthma, from which all communities and programs can benefit. But also, there are model solutions that reflect answers to challenges the healthcare sector really needs right now, particularly to integrate clinic-based and community-based care to achieve greater health equity. So we feel like really we have this treasure trove to share, and we want everyone to put it to use to help all children breathe better today so that all communities can be healthier tomorrow. And we know we have a lot of learning here. And we know that it takes time to share that in ways that really help people put that learning into action. And that's why we're hosting this 3-part webinar series, with this being the first opportunity for you to really sink in to this information. So the first of our 3 webinars. We will also build out resources related to these webinars on our site, AsthmaCommunityNetwork.org. If you aren't already a member, please make sure that you join so that you won't miss a piece. Our next two webinars will be announced on AsthmaCommunityNetwork.org. So if you are a member, you will hear about them and have a chance to register. Later this fall, we will host webinars on asthma disparities in indoor environments in a social determinants of health lens, as well as an additional webinar on multi-sector financing for healthy indoor environments for population health and health equity. So join the network for just a whole lot more resources. And we've been building this since 2008, and there's a great deal for you to find and learn there. Today's webinar is a deep dive into financing environmental asthma home visits within Medicaid, and we will look at one state example. And I really want to emphasize here that what has worked in California's policy environment may not work in the same way in other states, because we know every state is different, every population, clinical care systems, the community assets, the asthma burden is different everywhere. But what we also know is that these solutions kind of rhyme wherever we see them, because they're always doing kind of the same thing. They're always breaking down those silo walls, increasing coordination, and increasing the delivery of community-based tailored care to address the indoor environmental determinants of health where asthma burden is disproportionate, and doing it in a tailored way for that community. So you can learn from the California example, and I'm here today to help you listen for some of the transferable lessons. So we launched a series with financing within California Medicaid for environmental asthma home visits, because we want to make sure our stakeholders hear and believe that healthcare understands and is searching for partners to address and be accountable for the impact of social determinants of health on health outcomes, disparities, and cost. So Medicaid, as many of you know, is the public insurer for low-income people, including almost half of all of the children with asthma, and 86.2% of poor children, according to CDC data. So healthcare payers across the country and at all levels, including Medicaid and CHIP, know a few things. First, that factors outside of the clinic door determine most health outcomes and costs. Second, that new solutions are necessary to improve health outcomes and costs with quality. And third, and finally, that solutions to address the social determinants of health are often best delivered in the community. So healthcare leaders, like those that you're going to hear from today, are figuring out how to invest in solutions like indoor environmental determinants of health interventions, how to pay, who should pay, and what partnerships to support to achieve healthcare quality and cost requirements. And that is what you'll hear today through one state example in California. So today, we are honored to host Lori Copan and Dana Durham from California. Our first speaker today is Lori Copan. Lori is the daughter, granddaughter, and niece of a long line of coal miners and incredibly strong women from Eastern Canada. Having grown up in a mining town in the 1960s, she understands from lived experience the inequities, disparities, and health impacts associated with poverty, combined with indoor and outdoor air pollution. Her childhood experiences have inspired her to develop programs and processes that are driven by community partnerships, that foster bidirectional learning, and that strive to build community capacity to make environmental health and prevention efforts understandable and actionable. Lori has worked for 35 years in the public and environmental health fields and at the California Department of Public Health for 20 years. Lori has a doctorate in pharmacy and a master's in public health, community health education. Joining Lori to offer a Medicaid perspective from California is Dana Durham. Dana is the Managed Care Quality and Monitoring Division Chief for California's Department of Healthcare Services. She's responsible for planning, organizing, and establishing standards and program policies and procedures related to managed care plans, as well as monitoring the performance of those managed care plans. Over time, she has been involved in the work of numerous programs such as Health Homes Program, Healthy Whole Person Care Program, and California MediConnect. She currently leads several of the California Advancing and Innovating Medi-Cal or CalAIM initiatives, including California's In Lieu of Services offerings known as Community Support, which she will share with us today. Ms. Durham has an undergraduate degree from Baylor University and a graduate degree from Yale University. We are privileged at this time to have Laura and Dana with us today. So
we'll ask Dana, who is coming from the California Department of Healthcare Services, to go first and talk to us about the CalAIM community support benefit that includes possible asthma remediation support. And then if we can, we'll come back to Lori, who will describe work in public health to build workforce and to demonstrate the asthma burden, where, who, and how it was affecting the most disproportionately affected Californians, and how working with that data and advocates and with Medicaid, California has developed this terrific new policy solution that Dana is the best possible person to share information about with all of us. So with that, Dana, your slides are ready. And when you are ready, please go ahead and take the floor.
Thank you so much, Kate and Tracy. I'm going to ask if you can go to the next slide, if you don't mind. Great. So I want to touch a little bit about what we're doing in California, which is CalAIM, and it's actually California Advancing and Innovating Medi-Cal. It really is a way to take a different look at the way we deliver our Medicaid product. And as we do that, we want to view that through the lens of where is support needed and how can that support be given. We've started through really two initiatives that have begun. One is called Enhanced Care Management, and the second one is called Community Supports. Both of those are married with what we're calling population health management that will meet the needs of every single person who's on Medi-Cal, but enhanced care management and community supports are really for those who have additional needs and need a little bit of a higher touch. I'm going to go mainly over community supports because those are what our asthma remediation is part of. They're optional services that a health plan can opt to provide in lieu of a higher cost, traditionally covered Medicaid benefit. And so we have, and they're traditionally known in lieu of services, but we've changed the name to community supports because it's a little bit easier to understand. CalAIM has 14 community supports, and the managed care plans selected community supports to offer when CalAIM went live on January 1st, 2022. And they have the option to add new community supports every 6 months. I'm going to have you go to the next slide. And as you go to the next slide, I will say that we have, and at the end, we'll show you what a link to where there is a place where you can see each managed care plan and what they have selected as far as community supports. Some of our community supports are really about how we help people who are homeless. And those three really supporting the homeless are housing navigation services, housing deposits, and housing tenancy and sustaining services. We also have a couple that really work to make sure that a caregiver gets the support that they need. Those are our caregiver respite services and rehabilitation services. And then we have a couple that are really geared at getting people out of facilities and putting them either in an assisted living or getting them to a home. And those are the nursing facility transition or diversion to assisted living, and the community transition services, and that's nursing facility transition to a home. There are two that really deal with keeping people in the home, or actually there are three that really deal with keeping people specifically in the home, and those are our personal care and homemaker services, our environmental adaptation services, and our medically supportive food or meals or medically tailored meals. We also offer sobering centers and places that people can go before they get to hospitalization or as they're coming out. Short-term post-hospitalization or recuperative care. But the one that I'm going to focus on today is our asthma remediation. Originally, it started as part of our environmental service accessibility adaptations, but in working with advocates and others, we felt a need to break this out into asthma remediation because it is so needed and important, and it does affect and impact so many people's lives. And I'm going to have you go to the next slide. And with that, I'm going to start talking about what guidance we've given as far as asthma remediation goes. We'll start with the next slide that just basically describes asthma remediation overall. And asthma remediation is a physical modification to a home environment to ensure the health, welfare, and safety of the individual. And the goal is to enable the individual to function in their home without getting acute asthma episodes that could result in the need for emergency services and hospitalization. And it really is to make someone comfortable and deal with those social determinants that make someone a lot more prone to being hospitalized. Next slide, please. Some of the common triggers are seen here. I'm sure many of you are familiar with them. Dust or mold or rodents, pets, wood and tobacco smoke, chemical irritants, and gas stoves and space heaters. Now, of course, that's not all of them, but that gives you a glimpse of what you can find in a house that can exacerbate those chronic medical conditions and be effectively addressed through the removal or reduction of these triggers. Next slide, please. Some of the possible services that really are identified as being helpful are a mattress and pillow dust covers that are allergen impermeable, high efficiency particulate air filtered vacuums, integrated pest management services, dehumidifiers, air filters, other moisture controlling interventions, minor mold removal and remediation services, ventilation improvements, and then, having asthma-friendly cleaning products and supplies really can deal with really mitigating some of the problems that make someone more prone to have asthma episodes. Acute asthma episodes. Next slide, please. And one of the things we've done is really look at what populations would be best served by this community support. So those who are eligible for this remediation are individuals with poorly controlled asthma. And the way we're defining purely poorly controlled asthma is emergency department visit or hospitalization, or 2 sick or urgent care visits in the past 12 months, or a score of 19 or lower on the asthma control test. In addition to that, a licensed healthcare provider would have documented that the service will likely avoid asthma-related hospitalizations, emergency department visits, or other high-cost services. So if an individual is prone to having poorly controlled asthma, we want to get in front of that and help really mitigate what possibly could happen. But with that, I'll have you go to the next slide. And there are some limitations and restrictions on how the community support is operated. If there is another state plan available service that would accomplish the same goal of preventing asthma emergencies or hospitalizations, that must be used first if it has the same goal of reducing things within the environment. The remediations must adhere to state laws as well as local building codes. There's a lifetime maximum expense of $7,500. The modifications are limited to those that are of direct medical or remedial benefit to the member. Remediations may include finishing to return the home to habitable condition, but do not include aesthetic embellishments. And plans must provide the owner and member with written documentation that the modifications are permanent and that the state isn't responsible for repair, removal, or modifications. And those are just ways that we have found that we can protect the homeowner as well as the person living there, and really work to make those benefits where they are the last resort, but are available. And we do that because we want to make sure that as many people as need the community support can get the community support. Next slide, please. So when this is authorized, the asthma remediation, a couple of things must happen. You do have to have a licensed healthcare provider requesting the remediation. There has to be a written evaluation specific to the member about how the remediation meets the needs of the individual, and a home visit has to have been conducted to make sure that the remediation can be done and that's suitable. Next slide, please. And additionally, the members must be educated. The identification of environmental triggers commonly found in and around the home is one of the things that the member would need to be educated on, as well as using dust-proof mattress and pillow covers, high-efficiency particulate air vacuums, asthma-friendly cleaning products, dehumidifiers, and air filters. And then health-related minor home repairs, such as pest management or patching holes and cracks. Next slide, please. The allowable providers, now I have this list here. It's not a comprehensive list. If someone is really at a point where they are able to do the remediation, we know that this isn't exhaustive, but these are some suggestions of providers that would be allowable, such as lung health organization, healthy housing organizations, local health departments, and community-based providers and organizations. If there's someone outside this list, the department would be open to looking at that and approving that. We just want to make sure that someone isn't going into the house and selling or marketing something to the individuals who are getting the remediation. Next slide, please. So if you look at asthma remediation programs that are out there, there is a 56% reduction in asthma symptoms, 23 to 65% increase in being able to control asthma. There's a 34% reduction in asthma-related missed school days and a 36% decrease in wheezing, as well as a 43% decrease in rhinitis among adults. Next slide. As you look at utilization, the proportion of children with asthma-related emergency department visits decreased by 42%, and urgent care visits decreased by 37%, as well as there was a 71% reduction in inpatient hospitalizations. There's a significant reduction in emergency department utilization and 69% reduction in costs. And for the return on the investment, there's a 1.34 return on investment for patients with 2 or more past year emergency department visits. And before I go any further, part of the reason that these last two slides are really important is if you look at why the Department of Healthcare Services or Medi-Cal really feels like this is important, is it is that preventive, looking at how you help an individual stay healthy and you get them to a place where they can live a healthy lifestyle. And we really feel like this is one of those social determinants of health that really can be addressed in a way that can keep individuals healthy, and feel that it's so important to be able to mitigate these environmental risks for our beneficiaries. Next slide, please. We have a couple things that we've done to make the community supports accessible. We don't have our managed care plans contract with individuals, and we do not tell them what price they must pay for services. But what we have done is outline non-binding community supports pricing guidance, and that really is a kind of high-level approach to how pricing would potentially work. And with that, it just kind of gives a guide, and we also have disclaimers in there that other things must be taken into consideration, such as geography and the price of goods overall. But we've done that to kind of set a sort of expectation to begin the conversation. We also have a cap for the services, and we have that maximum amount that can be spent because we really want to promote consistency between programs and services. We are going to look at the cap as well as the pricing guidance as we go along to make sure that it aligns with what the costs are in the community as a whole. But our hope is one day to offer this as a benefit instead of an in lieu of service. And in doing that, we have to have kind of some guardrails around the amount of funding that can be spent. That's why there's the cap there. And next slide. We have some things that I want to show you as resources. There are billing and rates, and as you look at the billing and rates, I just described that, and it really is that we have our managed care plans working with our community organizations to learn how to bill. Many of our community organizations don't know how to bill, and so we will have them submit invoices, and that invoice must be included what we're calling encounter data, and that's just data that talks about what is the individual's illness, as well as we are asking providers to use what are called Z codes, and those are codes that talk about social determinants of health. As far as how to become a provider, it is really working with a managed care plan to become a provider and opening up that organization. And then we have a new program that we're standing up called PATH. And that PATH program provides additional technical support as someone is a provider to make sure they can learn about billing and they can become efficient in providing the services, as well as working with the managed care plan overall. The question of who can refer patients and how to make a referral, well, anyone can refer patients. And all you have to do is really call the managed care plans 800 number and their customer service and let them know that either you are interested in a community support if it's available, and it does have to be available through that plan, or you can get your doctor to make that referral, or if you're already working with a community-based organization who is offering asthma remediation, then they themselves can make referral. And I already went over how eligibility is determined, and really want to make sure that this program is spread as wide as it can be, because we just think it makes such a difference in people's lives. Next slide. This is just some resources that we used in some of the work that we've done. And we have this here because as you get a copy of the slides, you may want to look over this and click on the links and be able to look at these various resources, and then have you go to the next slide. And then we also have some more provider resources, and I'll make sure we get those out to you at some point. But with that, I will turn it back over to Kate.
Hey, and so this is Tracy. Dana, thank you so much for that amazing presentation. And, you know, I got to tell you, like I said, been working on this issue, you know, for many years. And when we held our first forum back in, you know, in 2007, and we were encouraging people to put the framework for, you know, for high quality asthma care in place, and really digging deep into tailored environmental interventions. And we got people to actually build that into their programs. The next problem that they ran into was recognizing that, you know, they were going into these homes and delivering the educational component and, you know, encouraging people to address their indoor environmental issues, but recognizing that they were sending, you know, patients back into homes where they could never hope to be healthy because they didn't have the services and the products and the equipment that were necessary to make those homes healthful places when it came to asthma remediation. And so to see this the way that you are, give me the next slide there, please, Pierce. You know, so to see the way that you are addressing this broad range of, you know, tailored environmental interventions and asthma triggers with everything from combustion appliance, you know, to mold and moisture, all of the things that we know are really important. And even though we know that there are still some, you know, limitations there, you know, but even the limitations are spoken to in the framework when we think about, you know, the need for a licensed provider to provide that documentation. But that really is just emphasizing that link between, you know, clinical care and community-based care. And so much of how the framework comes to life to bring asthma under control for the children that need it the most, and how to get those services and those key drivers sustainably reimbursed and paid for shows up here. And this is like what we dreamed of when we first started doing this work. And so to have that model there in California and something for folks to be able to tap into and see as a possibility, and to give that language for other programs to be working with their state Medicaid with, to you know, even the language that you use, you know, changing it from in lieu of services to community supports. There's such beautiful language there that our audience can tap into. So thank you so very much for that example. And I'm excited now, as you know, as we transition, so that we can hear kind of what the particulars of of a successful program looks like from Lori. And so, Lori, it is my joy to welcome you to the stage here.
Lori, this is Kate, and just before you start, I just want to help folks connect back to where we were. We got Lori back, thank goodness. And you just heard Tracy say that we were dreaming in 2007, 8, 9 of the idea that Medicaid and other healthcare payers would see in-home asthma care as necessary healthcare for prevention. And here we are today listening to Dana Durham, who is in charge of policy and programs for managed care in California, saying addressing indoor environmental determinants of health can help keep our patients healthy, and that's what we want. The way we got there, the story of how'd you get from that dream to this incredible Medicaid policy, you know, it's a work in progress, it's not done, and now we're going to hear from one of the representatives of that great work that happened between the dream and the reality. Lori Copan is going to describe for us what public health in California and many, many partners have done to support Medicaid and to be there to help the Medicaid program as it invested in SDOH to choose asthma and to choose home visiting. Lori, I'm so excited you're here. I'm sorry for the technical difficulties, and we've got your first slide up. The floor is yours.
Okay, can you hear me?
Yes.
Oh, wow. Fantastic. And I can even see my own slides. Thank you, everyone. I'm not quite sure what happened on my end with the technical difficulties, but I wanted to thank the IT admin staff who've walked me through this and held my hand. And thank you, EPA, for holding this amazing webinar, and Dana for demonstrating what is going to be done with CalAIM in all of the different service needs in California, but particularly in asthma. Just a quick shout out to Ashley Kissinger, who is our unit chief in charge of California Breathing, who is on maternity leave and should be presenting these slides, but is not. I am instead. And thank you for the CDC for funding our program, and of course to the taxpayers of California. We appreciate your effort as well. I think I'll just say a couple of words about what I'm going to present. So one is, it's interesting to me how we've all started in separate areas, but our paths have converged at this time historically to create the much needed services around asthma for the populations who suffer the most and who are disproportionately impacted. I want to today talk about how we as a public health program have worked to build capacity in CHWs, that as part of that in leaning into serving the populations most in need, that we are actually serving quite a few Medicaid recipients, and how we as a public health program have benefited from our partnerships with advocacy organizations. So next slide, please. So back in 2016, we were starting our asthma intervention, and we were previously working in another area, and we started to look at the evidence. And I've been committed for my entire career to working with promotoras, community health representatives, and community health workers who really serve the populations in a culturally linguistic way that many of us who are professionally trained can't. So we were pivoting our program and looked at how we could work with community health workers. And really the evidence is so strong around the quadruple aim of community health workers, as Dana mentioned as well. It is shown that building really solid programs for community health workers to serve their communities improves health, improves quality, reduces costs, and reduces disparities. Next slide, please. And certainly we have a lot of work to accomplish in California. If we look at the disparities in asthma, we see extreme disparities in the African American Black communities, with 5 times higher emergency department visits, 4 times higher hospitalizations, and 3 times higher deaths. We also see 30 to 40% increased burden in prevalence of asthma, emergency department visits, ED visits, and some hospital stays in Latinx and American Indian, Alaskan Native Californians. So looking at what our disparities showed us and what the evidence were, we moved on to create a program. Next slide, too. Next slide, please. So as we know, part of the evidence is looking at inequities and in asthma. And inequities are differences in health conditions and death rates across groups of people that are widespread, avoidable, unfair, and unjust. And I'm sure everybody on this call knows what the causes are of inequities in asthma, and they're related to these items here, and particularly to disadvantage to certain groups of people in our through racism, classism, and discrimination, and pollution, both indoor and outdoor, contribute to the burden of asthma, and also the things you see here on the lower level. Next slide, please. when we also looked in building our program at what is the source of payment for asthma ED visits, we see that Medi-Cal pays for the majority of these visits at 55%, and a smaller group is Medicare and other, that might be workers' compensation and self-pay, and private insurance contributes to about 25% of that. So given the strength of the evidence, who goes to the ED who for asthma severe care, and who are the sources, which are the sources of payments, our evidence really pointed to us building out an intervention for community health workers. Next slide, please. So our response in this was the Asthma Management Academy. What we intended to do was, this was back in 2017, when we kicked off the Asthma Management Academy, and we knew all of the happenings in the background that were going on with led by the Regional Asthma Management and Prevention Program in California, and all of the amazing groups who were participating in those initiatives, as well as we were also a member of the groups, particularly California Asthma Financing. And we felt that as a public health program, we could do more to create capacity in community health workers. Next slide, please, through the creation of this program. When we look at where our asthma burden is in California, we see that it's really all over the state, and we decided that through the Asthma Management Academy, we could initiate a population-based approach which considers intervening at all possible levels of practice, and that we would help to improve the systems that affect the health of those populations. So you can't see here, but Los Angeles, we have maps for the San Francisco Bay Area there, kind of in the middle of the state, and Los Angeles, where that purple star is, that also show a tremendous amount of disparity. And for us, because we are a public health program, we really need to look at where the largest burden is, and we define that burden by census tracts with the greater than 75th percentile for asthma ED visits, and that's how we decided we would approach different organizations and offer the Asthma Management Academy. Next slide, please. So you can go to our website, cdph.ca.gov/ehib, EHIB, and learn more about the Asthma Management Academy. But basically, we set out to train with evidence-based approaches, community health workers, medical assistants, health educators, and non-licensed provider in the scope of asthma, environmental triggers, and medications and delivery devices, guidelines-based care and monitoring, to the degree that CHWs could intervene, and best practices for asthma home visiting. And that's the basis of our training. Next slide, please. We intentionally, with our goals of participation, representation, equity, and a couple of others, we selected a training partner who was a community-based organization and was a community health worker organization with a track record of serving one of the most impacted communities in California with asthma. So we chose Comité Cívico del Valle, and we are now in our 6th funding cycle with them to deliver the Asthma Management Academy. Next slide. So the goals of the asthma, as you well know, is to reduce the asthma burden in the most impacted communities in California, as I said. And by working with a culturally and linguistically appropriate group of people through Comité Cívico del Valle, we would train other community health workers to deliver services that are very robust. Next slide, please. Just a little bit of the training logistics. It's approximately a 20-hour training over 3 days. It's rigorous knowledge-based training, as well as we use teach-back methods, which is an evidence-based approach for how patients or clients or community members can teach back to you what they're learning from you, so that you can test whether or qualitatively to have a discussion whether, what could be improved when they're managing their own asthma. There's also a competency test. In other words, we go through the knowledge increase. We teach about devices. We teach about peak flow meters. We teach about how to use an asthma action plan and asthma control test. And then we integrate all of that into a case-based competency test with a certified asthma educator. Next slide, please. It's a highly interactive training that is built on adult learning theory, which basically it implies that adults learn best by participation and by problem solving. And that is the best way to teach adults, and that adults do not learn by, especially adults who may not have had the privilege of higher education, by just accumulating knowledge and taking that accumulated knowledge and being able to make a change in their life and in the lives of others. Next slide, please. So as of right now, 2022, we've actually trained 569 community health workers with this rigorous method and supportive method by their peers from over 75 organizations. And next slide, please. The organizations are FQHCs, community-based organizations, managed care plans, and other types of organizations such as local health departments. Next slide. And what we see in terms of the data we've collected is that most of the people we've trained, and we're talking about community health workers, over 250 and 46% of our entire trainee group are from federally qualified health centers. And this is important because in California, over 65% of residents who receive services through federally qualified health centers or community clinics, as they're sometimes called, are also Medi-Cal recipients. So this is a way that our program benefits Medi-Cal recipients through FQHCs, and about a quarter of the people we've trained are through community-based organizations, and we've also trained directly managed care programs and others. Next slide, please. In terms of the knowledge and the skills, again, how to use the devices and proper use of the variety of medications that are out there, we see that participants scored 97% in these competency tests. And that those are the integrated case studies that go through a problem-solving perspective with a certified asthma educator. And this is also speaks to how individuals taught by their peers, community health workers, grow in agency, grow in competency, and grow in skills to be able to serve those folks who they will see in clinics or managed care plans or in the community. Next slide, please. We did follow a cohort of individuals over the last few years so that we can try to measure, well, what is the impact on patients or clients or community members who are served by a community health worker who we've trained at the Asthma Management Academy. And we've found, and I think this is based on a small number of people who we've been able to follow for over a year or two, that, and by small number, I mean 100 or 120 out of all the patients we've followed, that 83% of them had reduced emergency department visits and hospitalizations, 80% had improved asthma control, and 70% of them had fewer missed or school days. Next slide, please. Next slide. So I wanted to just reflect a little bit on how it takes, at least in California, it has taken all three areas of advocacy, public health, and Medicaid working together in an interdependent way, even though we all started out independently on different paths. And so I think what I want to say here is that, you know, we've all taken great advantage and learned so much and built partnerships through advocacy organizations such as Regional Asthma Management Prevention. We've developed separately, but it turns out we're converging in how we're meeting the needs, our public health program, and how, in effect, this public health program through advocacy has really worked together with Medicaid to get us to the place where we're at today in terms of being able to have a program like CalAIM. Next slide, please. On the left side of the slide, we see that advocacy groups really worked hard in 2016, 17, 18 to try to get a state plan amendment for Medicaid programs through DHCS, which is our California Medicaid administrator. And then in 2019, Governor Newsom allocated $15 million to establish asthma home visiting programs. And that was actually before the state plan amendments could be passed or approved. And through the Sierra Health Foundation, this money has gone out to at least 28 partner organizations. And the Asthma Management Academy has trained many of those asthma mitigation, actually all of them, about 125 community health workers through this program that was created with this $15 million. And there on the right, you see how we've worked through public health to train these 125 CHWs from the asthma mitigation program. So I do feel that there's a synergy and an interdependence on how we all fit into this equation. Next slide, please. And state plan amendment that was worked on through the coalition of people interested, community-based organizations, nonprofits such as Regional Asthma Management and Prevention, and clinics who serve people who are disproportionately impacted by asthma. And the first state plan amendment would allow Medi-Cal reimbursement to CHWs or allowed and promotoras for a broad range of work in communities across California. And the second plan amendment that was advocated for with Medicaid by groups of advocacy organizations will allow Medi-Cal reimbursements to CHWs, promotoras, and other non-licensed professionals specifically for asthma preventive services which I believe is specifically the CalAIM program that Dana just presented on. Next slide, please. And we, as a state public health program, have worked. We've been contacted frequently by Medi-Cal managed care programs to help with partner with them on quality improvement projects, and particularly plans who are looking to do a performance improvement plan or who are obligated to do a performance improvement plan through the state Medicaid program. We've collaborated on a variety of quality improvement programs, and through the asthma and through both the quality improvement initiatives that we've engaged in with Medi-Cal managed care programs, and through the Asthma Management Academy and the recipients, Medi-Cal recipients, and directly through Medicaid managed care programs, we've been able to promote implementation of guidelines-based asthma care, promote asthma self-management education, promote asthma home visiting, and to create linkages to asthma home visiting programs with managed care programs through CalAIM. And that is my last slide. Thank you for listening. I know that there were some questions that came out, and I will allow Kate or Tracy to facilitate that.
Lori, thank you so much. And we are going to be turning to questions here very quickly, but, I want to take just a second to make sure that that folks can, process what they've heard there from you, because, when I hear the commitment that this program has made to really, what you have done, this program is designed specifically to address asthma disparities, full stop, right? And, it's data driven, it's evidence based, it's invested in community based health workers and training, as really, it is as one of the key solutions for social determinants of health, including indoor environmental determinants of health. And when we started this work, we didn't have those words. We didn't have social determinants of health really as something that we were aimed at in 2007, but we were definitely aimed at encouraging people to invest in community health workers. And now it is really, the standard of care for addressing these issues, and it's programs like yours that have made that true. And so we appreciate everything that has gone on there so much, and it makes you payable by sources like Medicaid. And so it's a really valuable example for all of our participants. So, and there's so many more examples that you will find of this kind of work on AsthmaCommunityNetwork.org. You'll see a bunch of wonderful recorded webinars featuring our U.S. EPA 2002 winner for the National Environmental Leadership Award in Asthma Management, Utah's Medicaid and Public Health Partnership around environmental asthma home visiting. And so you'll also hear different approaches from California's statewide work, but one that reflects the same need for addressing indoor environmental determinants of health in asthma disparities. And so, please do visit the site so that you can avail yourself of that example as well. And if you listen to the Utah presentation on the network, you will hear that there's, more than one way to work with Medicaid on environmental asthma home visits and indoor environmental determinants of health. Champions need to know their local healthcare policymakers and Medicaid leaders to find the path that really suits you best. And so please join AsthmaCommunityNetwork.org and avail yourself of all the resources that we have there on our financing microsite. So I want to take a second to thank all of our, speakers from California for everything that they've shared. And as we move into the Q&A, I'm going to invite and welcome in Joel Irvis and Ann Kelsey Lamb of the Regional Asthma Management and Prevention Program, who will join our California panel for questions and answers today. And I'm excited to turn over the facilitation now to Kate Hastings, who you've heard throughout this call. Kate is a program contract expert expert for more than 20 years with our program, and we're just delighted. She has intimate knowledge of these programs and of this topic, and I'm excited for Kate to join us to facilitate this conversation with our presenters and our panelists. And so if our panelists, as you are able, can go ahead and join us on camera. Hi, everybody. Hi, Anne.
Hi there, and thank you for those who can be on camera. Dana and Lori, hopefully you can be part of our panel. I know the technology has not been as smooth as any of us would like today, and I just want to thank the whole team for your elegance and grace under pressure. Well done, everyone. And thank you to Joel and Anne from Regional Asthma Management and Prevention, whom you might have heard mentioned multiple times by our presenters today. Lori did a really nice job conveying what a partnership has been required between community-based organizations, public health and public health partners, and healthcare providers, clinical providers, and Medicaid, as well as politicians across California, if we're honest, to make all of this happen. It has been a partnership work. Everybody has been important. And just as you see those pieces coming together to form an asthma care system, you see them coming together to get this great work done. We had a couple of questions that kind of reflect. I just want to share with everybody, the speakers and the folks behind this webinar today. Several people said, oh my God, this is amazing. This Medi-Cal program that this person is describing is unbelievable. How do we get this? Can other states have this? Is this only for California? So as we all knew, there's a reason we wanted to shine this bright spotlight. It is incredible, but if you listen, yes, you can have this. You have to go get it, and you will have to work with partners to make it happen. But this is not an only one way kind of thing. I may ask Dana and Anne and Joel just to talk for a minute, if you could, about the many paths and approaches that have been considered to getting to where California is today. And, all the routes you've taken, and what folks can learn from you all is, I think, persistence, focus on the data, always be there to solve problems. And maybe Anne and Joel, you can talk a bit about just what was your role in all this? Thank you.
Sure, thank you. I'm happy to start, and then Joel, you can join in. First of all, thank you to the EPA for hosting this important webinar, and thank you, Dana and Lori, for your great presentations. Absolutely, I think Lori really underscored the value of partnerships in the history of this work, and of course, in moving forward as we get into the implementation stages, those roles will continue to be so important. Joel and I are with RAMP, which is Regional Asthma Management and Prevention, and we've been working in partnership with a broad network of stakeholders across the state who have been working towards sustainable financing for home-based asthma interventions for years. So yes, it does take persistence. We started this work many years ago, initially in response to a federal rule at the Centers for Medicaid and Medicare Services called the Preventive Services Rule that allows states to develop state plan amendments, like California did, to allow reimbursement to non-licensed professionals for certain prevention-oriented services. So one of the pieces that California just adopted was that they submitted a state plan amendment that was approved that allows the reimbursement to community health workers and promotorists for the education and in-home assessments. That, coupled with the CalAIM program that Dana described, that allows for the asthma remediation, covering the supplies and services to remediate asthma triggers, really allows for that comprehensive approach. And then you add on to that the critical component of workforce development that the State Health Department, through Lori's California Breathing Program, is bringing into this work. And what we're really seeing is coming together a comprehensive approach across the state of California. Now, a couple of these state policies can be adopted in other states, There are also a lot of great local solutions where we see individual Medi-Cal managed care organizations partnering with asthma home visiting programs, and there are some wonderful models that can be replicated across the country. Joel, do you want to add on?
I just want to emphasize the key partnerships that we had in place for so many years to make this happen. I specifically want to mention Children Now and the California Pan-Ethnic Health Network as two partnering organizations, as well as many, many, many others here in California that provided a range of input and cooperation for all aspects of our work. It really has been a phenomenal team effort. And I also just want to mention a couple of the pathways that we took. So in California, we, starting years ago, worked directly with the Department of Healthcare Services. Shortly after the Centers for Medicaid and Medicare Services made this preventive services rule a possibility, which is ultimately where we found some success. But we also ended up working through the legislature, through both legislative processes and budget processes in order to move this across the finish line. And then the other thing I want to mention as well is that I think some of this is about having a goal. In our particular case, we really wanted to take advantage of the preventive services rule, which finally we have some success with as of July 1st of this year. And we were responsive to some new opportunities. Years ago, we actually explored this the in lieu of services option that Dana really described as being the focal point of community supports. And at the time, it wasn't really on the state's radar. That changed over the last few years. They fortunately really wanted to move in that direction. And so that was really an opportunity for us to make the case for asthma remediation to be a central component of the community supports program. And I'll stop there.
Dana, I want to give you, oh, sure. I was going to give you and Dana a chance.
I just want to quickly just underscore something that could get lost really easily there in what Joel said about having a goal. And a goal that is higher than what it is than the mechanism or the vehicle. I think that, often people will get kind of, start perseverating over, we're trying to get a state plan amendment or we're trying to get, this particular thing. And when that doesn't happen, then they think game over. But being able to identify a goal that allows you to have access to multiple vehicles to be able to pivot and to change and to rethink what your strategy is what you're hearing here, right? And so being able to identify that commonly among your partners where everyone is agreed and focused on the same thing that gives you the energy to keep on going, because this was not an easy road for California to get to, right?
Dana. Can I
Yeah, I just want to add in that really that our advocates or community partners really were the key to moving this forward, in that we really had asthma remediation as part of home modifications, and they really pulled our attention to the fact that asthma remediation in itself should be a community supporter at the time in lieu of services. And they partnered with us in working on the definitions and really have done quite a bit of education as far as webinars, and really helped out in getting the message out there, as well as talking to managed care plans about asthma remediation. And I just cannot be thankful enough for the support that we have received from Joel and just to really get where we needed to get with this community support. We would not be there without them.
Well, thanks, Dana. And I'll say that it's certainly a mutual admiration society, in that we deeply appreciate that you and your colleagues and the department have been so willing and interested in having that conversation and having that back and forth. It's made, I think, everything a lot stronger and frankly easier to move forward. So thank you too.
And besides my delighting in that conversation that just happened in front of all of us, I hear something so important there, which is these folks kept finding each other and helping each other solve problems because nobody had all the information. One of the most important things was recognizing, oh, you're looking for me. You're looking for somebody who you can partner with to work in community to get health outcomes with some accountability for how that Medicaid money gets spent. That story is the same everywhere across the country right now. Everybody is looking for these partners. Every healthcare plan, every program needs partners who can deliver quality, accountable work. And so if you don't know who those partners are in your state, it's not because they're not there. So you can find them, you can keep looking, and we're trying to show you one story here. And we wouldn't be spotlighting California if it wasn't an amazing success story, but they're not singular. There are many, many, many pictures that look just like that system graphic where you see high-performing collaborations and partnerships coming together to integrate clinic and community care and to get it to people where they can receive it in their home with people who look like me and know my life story, so can help me, really help me. This is happening everywhere, and California gives us a great model of what's possible. Now, folks on the phone from California, our audience is very clever, and they went immediately to some big questions about problems. So let me throw some of those out for you and talk to us about how you have either worked through some of these or maybe what you think you might do. The first one is around non-owner occupied housing, rental housing, housing that might, let's say it might be substandard housing. There might be some housing inspection issues. How have you all thought about addressing such issues, first of all, so that anyone who needs it can access these services? And secondly, I know, because I remember reading about it, that you all tackled some of this, that you didn't give up on renters at all. You're front and center. Anne, Joel, Dana, and Lori, have at it.
Yeah, I mean, I think renters are central to our work because we know that asthma inequitably impacts low-income communities, many of whom are renters. So in addition to supporting the delivery of these evidence-based services, we also support policies to protect tenants and hold landlords accountable for providing safe and healthy housing. And we actually help facilitate the California Healthy Housing Coalition that has passed some state legislation to ensure that the housing codes identify mold as a substandard housing condition that affects health. And that makes sure that when pest infestations are identified, they're not just sprayed to kill the bugs, but they're actually addressing the root structural problems. And so we are thinking about balancing the policies to maintain safe and healthy housing with the services delivered to the residents that are living in the housing.
I'll add too that I think this is this also really gets back to the skills and competencies of our workforce that are actually conducting the home visits, right? I think they are so good at working with a client to understand what their living situation not only is like, but how it might be fixed and how the relationship with the landlord might be impacted. And this is a credit, I think, to the great work that's done by the Asthma Management Academy and to the the perspectives that the home visitor brings, where they are not going to do something that is going to cause harm to the client or their family, right? And so their ability to work with clients to understand what they feel comfortable doing in terms of reporting a violation or a problem, I think really just can't be understated. And it's a credit to the workforce and the workforce training opportunities we have here in California.
So I am sorry to jump in and do this, you all, because there are so many questions I would like to share. And folks who have asked questions, including many of whom I know by name, and it's great to see your programs here today. I am thrilled to see King County and CHW Solutions and so many others here listening and learning. I will make sure we get back to you, and we will provide all the technical assistance we possibly can to you. This is EPA's deepest commitment is to help communities advance these systems. And so I'm sorry we can't answer you today. We ran longer than expected and had some technical problems, but we will get back to you. And I really want to turn it over to my dear friend and, personal hero, because she's been at this for, I can't say how long, because she can't possibly be that old. So Tracy, who has been working to protect children literally everywhere so they can catch a breath. Can you bring us home and close us out today? Thank you so much to the speakers. Thank you for all your time with me over all these months, and you killed it. So thank you. Tracy?
Excellent. So again, my thanks also. Before people leave, Pierce, can you please pull up the polling question, because we do want to test our knowledge from beginning to end. And also, your questions that you have submitted to us, know that those questions will feed into our programming as we move forward. The poll is up. Please go ahead and start to respond to the poll as we start to close out here. But yes, the questions that have come in, we use them to help us design our future offerings, and so they are not lost to us. We will definitely be returning to those. And we also want to see kind of where your knowledge base has shifted here, and where we want to continue to invest in other program offerings as well. So Pierce, let's go ahead and close out the poll and see what it looks like now. Hey, okay, so my heart is going pitter-pat, because the no, I don't know the how to approach healthcare payers has reduced tremendously, and the yes has gone up, and knowing a little and wanting to know more is wonderful, because that appetite that you have for knowing more will be fed, and it will be fed right here. So as I wrap up, I just want to just thank everyone for the time that you have spent with us today. This is really, the EPA's learning objective. This is what we're after, with all of you. And so we want to thank you for your time, and please join us as we continue throughout the fall with our webinar series to continue this conversation. You will see other amazing leaders like you have seen today, and like you have witnessed, and your leadership in participating and in feeding those questions, it really helps to nourish our community as well. So please do join us as we continue with this series and start to really address the indoor environmental determinants of health that are going to make all the difference in the lives of children across the country who are struggling with asthma. So thank you so much for your attention today. Thanks to all of our speakers, and we look forward to seeing you later on this fall.